Let's assume that I have access to a psychiatrist or a psychologist. And let's assume that I think I have depression. When I reach out to a psychiatrist or a psychologist and I get a consult with them, what does the typical treatment journey look like for someone today? I think earlier in the conversation you mentioned that we need to have more tools, and perhaps this is where your interest in psychedelic medicine sort of stems from. But I'm interested here in what the current paradigm looks like. What is evidence-based sort of best practice for someone who presents currently in Australia with a mental health condition?
I think at the moment in Australia, there's a discrepancy between best practice and what's actually happening on the ground. So most people with, using the example with major depressive disorder, most people with depression are going to access help through a GP. It's primary health care. It's the first point of call. And unfortunately, many GPs will respond to a patient presenting with depressive symptoms by prescribing an antidepressant medication. We've talked about the per capita use of cocaine. The per capita prescribing of antidepressants in Australia is high. I'm not sure where we're ranked in the world, but we'd be in the top 10. We consume lots of antidepressant medication, and antidepressants are effective for people with severe depression. In fact, they can be life-saving. It can be the difference between someone taking their life and not taking their life. So these are absolutely life-saving drugs, but they're being overprescribed, and they're being prescribed to people that might not even have depression. They might have a situation that's leading them to feel stressed and anxious and stuck, but they're actually not depressed. It's situational, and providing them with an antidepressant drug is not going to solve the problem. They need to actually fix the problem that's causing them to feel that way. And one of the problems with antidepressant medications is they can be quite difficult to come off. So a number of my patients have tried to come off an antidepressant and not being able to come off, not only because of the depression relapsing, but because of other symptoms caused basically withdrawal. But we don't call it withdrawal when we're talking about antidepressants. Instead, we've come up with this medical euphemism called discontinuation syndrome, which it's essentially the same thing. So yeah, I think that's a concern. And then comparing that with best practice, and look, there are some good GPs out there that the medication would not be their first line of treatment. So I just want to make that clear. There's certainly not all GPs are doing this. And to be fair on the GPs that are, we live in generation medication. People go to a GP and they want a medication. If you don't walk out with a script and you've paid for this appointment, you're probably going to feel like you've been hard done by. And these doctors are trying to run businesses. So I really get that. But best practice would be to set up a mental health care plan with the person so that they're able to be referred to a psychologist to engage in talk-based therapies, so cognitive behavioral therapy or any other based psychological intervention. And for most people, that psychological intervention is all that's required for their depression to remit. Some people have treatment-resistant depression, and that's where things like these new treatments with psychedelics are showing potential promise. But essentially, whether it's depression or PTSD or substance use, the first line treatment should always be an evidence-based psychotherapy, and then medications can be used to augment that. So we know that people do better. So people that are just prescribed the medication will see some improvement. People that do the evidence-based psychotherapy will see some improvement, maybe some more improvement. And if you combine them together, you get even more improvement. So but if somebody's got quite severe depression, maybe the GP then needs to both do a referral to the psychologist via a mental health care plan and prescribe some medication. And if none of this seems to be working, then the GP can make a referral to a psychiatrist.
Hey friends, are you ready to take your fermented food game and gut health to the next level? Look no further than my digital guide, Plant-Based Ferments. Inside, you'll discover some of my favorite recipes, including my soy labneh and homemade kombucha. Visit theproof.com/ferments for more details. That's theproof.com/ferments. Okay, that's enough from me. Let's get back to the episode. You said most people will get benefit from psychotherapy. So cognitive behavioral therapy being an example of psychotherapy. Do you have a sense for what percentage of people are slipping through the cracks where the current treatment approach, best practice, psychotherapy using cognitive behavioral therapy and other therapies, what is the percentage of people with depression or anxiety or PTSD that type of treatment is not helping or not helping enough?
Yeah, so it's very much dependent on the condition. So with some mental health conditions, we have very effective treatments. So psychology has learned how to treat phobias and panic disorder very well. Response rates upwards of 90%. So less than 10% of people are not responding to these treatments. And I guess, phobia may be something that's less debilitating, but panic disorder is essentially when somebody has a phobia of their own internal sensations. Their experience if you have a phobia of spiders and you see a spider, you're having a panic attack because you see the spider and that triggers the panic attack. With panic disorder, there's no external stimulus that's triggering the panic attack. And so understandably, people not knowing when it's going to happen, it's very unpredictable. They just randomly have this panic attack for no apparent reason. It starts to become debilitating and impacting when or where they will go out and things that they may not do anymore because they're concerned about having another panic attack. And even with panic disorder, upwards of 90%, so less than 10% of people not responding to that exposure-based psychotherapy. Then with things like depression, less effectiveness, but still, maybe 30% of people don't respond to current treatments, and even a smaller amount of those people then have treatment-resistant depression, which means that they don't respond to a number of treatments. Typically, there's no standard definition. I tend to call it 3 treatments. So they've tried at least one evidence-based psychotherapy and 2 pharmacotherapies, 2 medications, or vice versa, something like that. Then with conditions like PTSD, estimates are up to 50% of people with PTSD don't respond to those first-line evidence-based interventions. And so that's really where my interest with MDMA came about, because that was my experience as well. A number of the people that I was treating were not responding well to the treatments. Some people would find the exposure process that we do for PTSD treatment to be overwhelming and want to drop out of treatment. Other people have ways of regulating themselves so as not to sort of put on a mask, I guess. So they're not really reprocessing. Like, it looks like they're going through the motions, but they're not really doing that. And that really accounts for that 50%. And ultimately, it depends on other things, So with substance use, for example, we know that prognosis is worse if you've got PTSD combined with a substance use disorder. Hence why I was seeing the poor outcomes where I was working. And as a consequence, there's quite a lot of variability in the estimates of how effective these treatments are. So anywhere between sort of 25 and 50% has been an estimate of the number of people who respond to the existing treatments. So 25% is very low, but it depends on how you measure response and the research methodology. So quite a large variation when it comes to estimates of PTSD. But that was really my interest in MDMA, was because this was one of the mental health conditions for which psychology hadn't yet developed a treatment that was good as our treatments for panic disorder, our treatments for depression, etc. This is an area where we need new treatments because the current treatments are not working for a number of people. And when that first-line treatment doesn't work, oftentimes they will be prescribed an antidepressant medication, which may treat some of the symptoms and provide some relief, but it's not treating the cause of the PTSD, which exposure-based CBT and EMDR EMDR and other evidence-based treatments, they're trying to address the root cause, and MDMA therapy is the same. It's actually trying to address the root cause rather than giving somebody something they have to take on a daily basis just to manage the symptoms, because essentially that's what I was seeing in substance use treatment anyway. That's why people were using the substances, for the same reason that they would be prescribed an antidepressant. Obviously, an antidepressant has potentially a lot less side effects and ideally is going to be less detrimental to the person's quality of life than psychoactive substances like alcohol are going to be. But ultimately, it's kind of the same thing. We're just putting a Band-Aid on it rather than fixing the problem in the first place.
Right, rather than going completely downstream to what was causing that mental health condition at the outset.